I've been asked by my trainees to give a short talk on what sort of scanning we do when we're asked to exclude a thoracic aneurysm or a thoracic dissection, because apparently this is a question we are asked not infrequently. And I always love to start with a smack talk that I heard a few years ago, talking about chest pain plus one. In other words, you do need to think about thoracic aneurysm or dissection when your patient has chest pain plus one other symptom. Another symptom might be pain below the diaphragm, or it might be a focological neurological deficit, or it could even be the classic sort of pain, ripping, tearing, sudden severe, going through to the back. When you're asked, can you rule out a thoracic aneurysm, please? If you're just wielding an ultrasound scan, your answer has to be a definite no. But what you can do is risk stratify. What I mean by this is that we add up different pieces of information, and the chance of a thoracic aneurysm can become increasingly low. I'm basing this talk on a paper by Nazarian, who's done a little bit of research in this arena. And what he talks about is combining different pieces of information in a typical Bayesian landslide, where you start with a pretest probability which we ascertain via history and risk factors and physical exam, and we then add on other tests such as a D-dimer and a transthoracic echo. And what happens is, if each of these pieces of information is negative, then we can come up with an increasingly unlikely scenario of thoracic aneurysm. Now, I repeat, none of these tests by themselves will ever rule out thoracic aneurysm, but when you get a negative risk score plus a negative D-dimer plus a negative echo, then your chance of having a dissecting thoracic aneurysm is extremely, extremely low. Nazarian estimates at 0%. Now, the risk score that he talks about is something that we would start with pretty much anyway. We ask the patient about their history and risk for aortic disease, Marfan syndrome, for example, or recent aortic manipulation or trauma, or known aortic valve disease. We then ask about the clinical features. What's the nature of the pain? And then we look for high-risk physical findings such as differential BP or pulse deficit. Now, of course, these things are very insensitive, so we're unlikely to find them. But when we do find them, they're quite useful. Now, if this risk score is any greater than 1, then we are encouraged to go to formal fancy imaging such as CT angiogram. But if this risk score is less than 1, then we progress to a D-dimer and an echo. I'm not going to talk about D-dimers because you all know about those, but I'm going to spend the rest of this talk looking on echo, what we can see with fairly simple manipulation. The first and most important thing, of course, is to look for a pericardial effusion. In this case, we're looking to see if there's a hemopericardium, but we don't have to be that fancy. Any pericardial effusion should set off warning bells. We have to look closely at the aortic valve, because your bicuspid aortic valves, for example, will predispose you to pathology. We're also looking to see if there's an aortic regurg murmur, something that you're supposed to look for in your physical exam but can be very hard to hear. We are going to take a few looks at the thoracic aorta, but we can't see the whole thoracic aorta. We can get a couple of glimpses from separate windows. And finally, don't forget, you can look at the abdominal aorta, because pathology in the abdominal aorta increases your risk of having pathology elsewhere. Now, last but not least, you all hear about a dissection flap, but honestly, that is a rare thing to find. Even if you know it's there, it can be hard to see. So we're not going to focus so much on the dissection flap. We're going to focus on what we call the indirect signs of thoracic aneurysm, the top four. First of all, look at the pericardium, and you should look carefully in all views. This pericardium, for example, a subcostal short axis view, was in fact a patient that turned out later to have dissecting aneurysm. Now, I'm not sure I could identify any abnormalities here. The little bit of fluid anteriorly I might have mistaken for a fat pad, although if you look at it really, really carefully with a retrospectoscope, it moves pretty clearly. Here's another one where I know this patient had a dissecting ruptured thoracic aneurysm, and looking at this picture, I think what stands out to me is what's probably mediastinal hematoma down here between the descending thoracic aorta and the left atrium. So it's really not necessarily an easy thing, because remember, hemopericardium is not black, it has grey speckles in it, and if it's just anterior, most of us would assume it would be a pericardial fat pad. Anyway, you do have to look for a pericardial effusion, because if you see one, it usually means you're in the presence of severe disease, no more hanging around. Now, the second thing to do is to look at the aortic valve, and again, we want to look at it in as many different views as we can. One of the first things to ask yourself is, do the leaflets meet in the middle? Because one of the characteristics of your congenital aortic valves is that they may be asymmetrical or skew. Have a look at this one here. Instead of the usual upside down Mercedes-Benz sign, we've got a single coaption line across the middle going from about 10 o'clock to 4 o'clock. We want to make sure that the leaflets meet and close correctly. This one, in this particular view, we expect to see two leaflets that meet in the middle. And instead, we seem to be seeing one leaflet that doesn't even open. So it cues us into the fact that this valve formation's a little bit odd. The other odd thing we see in this picture is that we don't have the usual bulge of the sinuses. We don't have the sinotubular junction, that little waist. Instead, we have what's called effacement of the thoracic root, this smooth profile. Now, if you can, you try and count the leaflets, and you can really only do this in the parasternal short axis, or if you're really lucky, in a subcostal short axis. Now, you can have anything from 2 to 4 leaflets, although they're increasingly rare. Just as much as the number of leaflets, the orientation of the leaflets may help you. But this is a hard call, and it often needs really high quality machines to see the leaflets clearly. What we can do more easily in emergency is look for calcification of the leaflets, which you might get in stenosis or abnormal leaflets. And even more importantly, we look for regurgitation or abnormal flow in the thoracic root, because any aortic pathology means we're more likely to have thoracic aneurysm, poststenotic dilatation, those sorts of things. And here is another aortic regurgitant jet. This time we're seeing it in the parasternal long axis view. This is not the view you usually find it, but when you have a big aortic regurg, you can see it as this area of speckled aliasing back in the valve through the LVOT. So we've looked at the pericardium, we've looked at the aortic valve itself. Now we're going to look at the aortic root, and the best place to look for this is in the parasternal long axis view, one of the higher windows rather than the lower windows. But you do find that if the aortic root is abnormal, it will intrude on just about any view you have. Here you can see a really magnificent bulging aortic root in the apical 5-chamber view. Here you can see a really big aortic root in the parasternal long axis view, where it's almost obliterated the left atrium. Any increase here greater than 4 centimeters should certainly prompt you to get formal angiogram. And in a subcostal view, again, this funny white bulge in the middle of the picture is actually a very dilated aortic root. And one of the characteristics of a dilated aortic root is that you can't get rid of it. You can't pan under it to get a normal 4-chamber view. The question of effacement or not, you've already seen this picture here where we don't have the waist of the sinotubular junction. Here, in this one on the right, which does have the aneurysm, still has the sinotubular junction. So effacement is not necessarily a sign. Good if you've got it, but not excluded if you don't. Now, when we actually measure the aortic root, believe it or not, there are at least 4 measurements that we should take. And where you place the calipers is critically important. However, realistically, if we're looking for thoracic aneurysms and dissections, we're not going to be quibbling over a fraction of a millimetre. Now, when we measure the LVOT, that's before the valve, we measure inner edge to inner edge when the valve is open. But when we measure the aortic root, and this is bound by tradition and cardiac surgery in the old days when we had to use M mode, what we do is we should be putting this cursor just outside the wall, in other words, the leading edge to the leading edge, to outside this wall. So we're going outside the aortic wall here, but inside the aortic wall on the deeper margin. And that's because, due to tradition, these are the measurements that the surgeons use on whether they decide whether or not to progress to surgery. And the measurements we'll be doing in the aortic root, there are 4 of them. There's the intersinus distance. We have the sinotubular junction, which should be smaller. And then we have the ascending aorta here. Now, if the views are really poor, you can do a funny, fancy manipulation called a right parasternal long axis. In this case, instead of having the patient lying on their left side, you lie them on their right side. You then put your probe in your usual parasternal long axis view, but you then slide it in the same orientation diagonally across the sternum, aiming for the next rib space up on the right, just beside the sternum. So it's often one rib higher, and your patient's leaning to the right. And what we're trying to do is encourage the aortic root to flop anteriorly onto the chest wall surface so we can see it. And this is the sort of view you get. And again, I think the aortic valve's in here. Well, I'm never 100% sure on this view. We're looking to see the ascending arch of the aorta. Actually, I think it might be here. The next view is a tricky one to get, and you really have to practice it. It's called the suprasternal notch view. And this is when we're actually going to put the probe vertically in the suprasternal notch. If possible, get the patient to extend their neck. We have to turn the chin to the side because the chin is right where you want to be putting your probe. And then you place the probe marker at about 11 o'clock, 10, 11 o'clock. 1 to 2 o'clock, not 10, 11 o'clock. I'm in the northern hemisphere, I'm getting a bit confused here. And we fan ever so gently side to side. And what we're looking for is a little bit of the ascending arch. In cross-section, we may be lucky enough to see the pulmonary arteries. And we want to be looking for the carotid, the innominate, and the subclavian arteries. Again, we're looking for 3 vessels coming off the top. It can be hard to see them all in the one view. We're looking for the diameter here, needs to be less than 3 centimeters. We are looking to see if there's any dreadful flaps. If you really fancy, you can put a Doppler down the descending aorta, because flow reversal may be one of the few signs you have of genuine and significant aortic regurg. So that's the suprasternal view. You have to practice it. Here we've measured it, and on the right we put the colour flow on it. Now it does look here like we've got 2 different colours, the blue and the red, but this here is not a genuine yin-yang sign. I'll show you a genuine yin-yang sign next. Here we go. See, the yin-yang sign here is a lot more definite, and the blood goes through the true lumen earlier and then the false lumen just a little bit after. Now the thing to remember about dissection flaps is if your probe is not perpendicular to the dissection flap, if your probe beam is parallel to the dissection flap, you may miss it completely. It may not show up. So actually seeing the flap is a gift and a benefit, but don't panic if you can't see anything. In those suprasternal views, you can actually rotate the probe 90 degrees because it's easier to be perpendicular to a flap in a short axis view. Here's a characteristic flap, acute flap in a short axis suprasternal view. And the thing you must notice is the mobility of it. You can tell a flap by the way it responds to the aortic pulse. It really has a very mobile, beating sort of movement. Very sharp movement. We try and get pictures of the descending aorta, and there's sometimes a glimpse available in the apical 2-chamber view. The thoracic aorta in a healthy person will run straight along the back here, but it can be very hard to see in the older patients. And if you have an ectatic descending thoracic aorta, it will move in and out of the plane. If you see a nice thin straight one, that might be reassuring. But here, I think this is actually reflection artifact, because it's moving exactly in time with up here. But we can see a slightly ectopic aorta here. As I said, it's more reassuring if you see a normal straight one. And finally, the abdominal aorta. And this is because pathology in one part of the aorta increases the likelihood of pathology in another. So if you see a pristine, thin, straight abdominal aorta, you're less likely to have thoracic problems. If you see an ectatic, enlarged abdominal aorta, then you can imagine the rest of the thoracic aorta probably looks the same. Now this is actually a coronal view from the mid-axillary line. We're looking through the liver and we can actually see the aorta very deep. But again, you can see that really characteristic flapping of the bright dissection flap as it responds to the aortic pulsation. It's the movement you've got to see. And here, again, this is abdominal aorta, but as you can see, there is what looks like a clot or a thrombus around the outside. That's a bit of a warning sign, saying this aorta is not going to be normal. And here is again a dissection flap, which is actually extended right the way down, right from the aortic root down to the lower aorta. And again, you can see that really typical movement. Now you can imagine if you had your probe in longitudinal on this aorta and you were either just to the right or just to the left of that flap, you may not see it at all. But when you turn 90 degrees and you see the aorta in cross-section, you'll see more likely to see the flap. So in summary, what we do with an echo probe will never exclude a thoracic aneurysm or dissection. Although, of course, if you're really lucky, you can rule it in. But what we're doing is adding another piece of weighted information. We'll have the risk stratification tool in the same way as you use a PERC rule. We have the risk for aortic aneurysm. We have the D-dimer. If it's high, we're concerned. If it's low, we're less concerned. And then we add in any abnormalities we can find with the echo probe, which, as you know, is a far more sensitive tool than physical examination, where really all we're doing is improving the physical examination as we look for risk factors. So it's really a combination of Bayesian unlikelihoods. I hope that helps. And finally, here is a really nice simple case report that describes the process of using echo.